Yes, 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 yes. Because 121 audience is a huge audience.
Sir,
You can take whatever case, second case or third case or fourth case, whatever case.
sir.
After that,
Hello.
the formal inauguration.
नहीं आ
Whoever
रहा.
joins, they can discuss their subject.
Hello.
And then once that is over and everyone
Hello.
then we can take it also get the formal inauguration.
Yes, sir. Yes, sir.
Hello.
The only issue is all the guys who are there and my
ఏం చేస్తున్నావు?
there, Neeraj, Ravichandra, Sai Swaroop, and Chandramon are there anyway.
Yes, sir.
So I was asking whether Dr. Neeraj, Ravichandra, and
కాదు అరవింద్ సార్ని కూడా యాడ్ చేయను. అరవింద్ పాండే.
whoever has to discuss the case are the people there. Just send a message.
मैंने అదేం లేదు ఇంకా ఒక 10 వస్తుంది.
Sir, instead of Sai Swaroop, Ankit Anand will be. They have exchanged, sir. Ankit Anand will be there.
Sorry, sir. Dr. Ganesh, sir. Dr. Ganesh has joined us. Hello.
Oh, fantastic.
Dr. Ganesh.
Oh, fantastic.
I think. Sir, Dr. Ganesh.
He may be muted. Just check it.
I think I've got in here.
Yes, yes.
You have to put. Can you hear
Dr.
me?
Ganesh, sir, are you able to listen to our voice? I am from the technical support team.
I can listen to you. It is just that I'm not able to. I can see you all, but I can't. Yes, now it's okay. Now you're fine.
And Dr. Gopichand, sir?
Yeah, that is okay.
Yes.
Dr. Arvind has to join.
Dr. Gopichand, sir, I've sent you one link on your private chat.
Yeah.
That is the
Sir, good evening, sir. Ganesh, sir. Good evening, sir.
Good evening, sir.
Good evening, sir.
Dr. Gopichand, sir, I've sent you a link on
Arvind,
which you will get all
I'm
the
okay.
questions
I've joined.
from the audience outside the link, sir.
Arvind,
So,
okay.
what am I supposed to do?
Sir,
Malik,
I've
sir.
sent
Good
you
evening, sir.
a link with the ID
Good
and
evening, sir.
password in
Malik,
the
sir.
private chat.
Okay.
Sir, you have to open that link
Huh.
and you will receive all the questions coming in from the audience of the webinar.
Okay.
So you can select the appropriate question and you can take it on the panel, sir.
Okay.
Okay, sir. Okay, sir.
Yeah. So,
Arvind, I've joined. They've given a new this thing. I've joined in.
start, sir. Dr. Jagdishar, sir, you can start.
No, I have joined. It's okay. I'm okay now. I've joined. I joined and video and everything is on. The problem was there and yeah.
Sir, Malik, sir, shall we start, sir? Gopi, sir.
Yeah, you can start.
Sir, very good evening, sir. Very good evening, dear friends. Hope you and your concerned are doing fine in this COVID situation. Very nice to be here this evening among the stalwarts. There has been a long gap in meetings on the service platform because of COVID situation. After this long gap, we thought the Euro rounds would be more appropriate to initiate the journey again as the final practical exams of postgraduates are approaching. With these words, this evening, I would give introduction to this meeting and I shall hand over the proceedings to Dr. Gopichand, who is the director of this program. Dr. Gopichand, can you
Sir.
take the proceedings, sir?
Dr. Mallikarjun Reddy, sir. Dr. Mallikarjun, I request Dr. Mallikarjun Reddy, sir, to please give us the welcome address. Dr. Mallikarjun Reddy will give the opening remarks. He is our president for the state association, both AP and Telangana.
Sir, you are not audible, sir. I think you are talking.
No, I am off the mute. Now it.
Malik sir, Malik Reddy sir, Mallikarjun Reddy sir, your audio is very poor, sir. I could not tell you. Very poor audio from the beginning. Very feeble voice is there, sir.
Is it better?
No, sir, it is very feeble.
It's okay.
Is it better?
Okay, sir. Please carry on, sir.
Yeah, thank you. At least to start off, it's a good. Just hope that all this would help our graduates. It's unfortunate that they have lost almost 1.5 years of their training program in majority of the medical colleges. So hope this would be of good help to our guys. And then take it off from here. We have a very good faculty to take things from now on. So thank you very much. I think we go ahead with the program, Gopi. Thank you.
Dr. Mallikarjuna sir, he is the president for Urological Society of India. Thank you, sir, for joining us in spite of your busy schedule. Sir, you are mute, sir.
Yeah, thank you, Gopi. Thanks, Sogas, for this opportunity. And I'm a member of Sogas, so there's nothing to invite me into this field. And I think I'm one of the players who's playing in the field, so there's nothing to invite into me. Thank you very much. But one thing is true: COVID has changed lives. COVID has changed our teachings also completely. We have, in the last 2 years, I think the majority of the residents have not been exposed to the true clinical work where they're supposed to be. It's not happening off late, and even the teaching programs have been shifted onto a virtual platform. Hope the treatment will not shift to virtual platform in the near future. But I think we need to make all the efforts to at least see that the people are well trained in this next few years, so that they'll be able to take over as a proper urologist in future. For this, all the efforts what is being done by SOGAS, we appreciate that, and the OSCE is a new one being done, and I think you also incorporated into it. And I think that is the way of future exams. But I don't think that is the end of it. Possibly we need to make more, not just urologists with degrees, but more trained urologists who can practice urology. And I think with the who's who of this India, Dr. Ganesh, Ravi, and all, and Changalarayan and all, you should be able to train these residents in a much better way. Thank you, Gopi, for this opportunity, and all the best to this program.
Thank you, sir. Dr. Keshavmurthy, sir.
Keshav, I think he's left. I think
I think he came first at 5 o'clock itself. We are very thankful to him. He came very early, even before the program started. After that, some hiccup with the technical hiccup. Thank you very much, sir, Keshavmurthy, sir. Sir, Dr. Changalarayan, sir, please. You're mute, sir.
Good evening, everyone. Good evening to SOGAS. Good evening to Hyderabad Urological Society. Good evening, Chandramohan sir raised his hand, and Malik sir, everyone, Ganesh sir. It's a really nice thing, sir, actually, because of late we have been teaching our postgraduates, and what we are seeing is a little drop in the psychological aspects, because every now and then a kith and kin of them is getting infected. And every 3 weeks or 4 weeks, our postgraduates are going for COVID duties, working in the COVID wards, training themselves. And as Malik sir said, nearly 1.5 years they have lost of urological training. So in this scenario, having a program like this is not only a teaching program for them, it is only a big boost to say that we teachers are always with you and behind you. So it is really a big initiative and a good initiative from SOGAS. I wish the team of teachers, faculties, organizers a success for this program. Thank you very much, Gopi Chand sir and Jagdishwar sir, who had the trust in me to bring me in for this inauguration. Thank you very much, and please go ahead with a nice program. Thank you.
Thank you, sir. So, sir, we'll proceed with the case.
Yes, Gopi.
Yes, sir, please.
Yes, sir. Thank you, sir. Thank you very much. Sir. Dr. Arvind Panda, please, you can proceed with the case. I think your resident, Dr.
Chandra Prakash, kindly
start is there.
Presenting.
We have our faculty, Dr. Ganesh Gopalakrishnan, sir, and Dr. Samir Trivedi will be joining. Till that time, Dr. Arvind, please do the play the role of faculty as well in this. And the residents can, most of you are in the panelists, so anybody can ask questions if needed. The student, Dr. Satish and Dr. Varun is there.
Yes, sir.
Thank you, Dr. Satish. Dr. Varun and Dr. Chandra. Any other student who want to? Dr. Varun, you are there? Yeah. Any other final year student who want to come and answer the question free to become the examinee? Any final year student? Dr. Dheeraj, you are there? Dr. Dheeraj from Nizam's Institute of Medical Science. You are there?
Yes, sir.
Yeah, you will. You can come onto the video as well, and
Please come on with the video.
And you can answer, Dr.
Hello.
Satish. Yeah. Dr. Samir, you can also switch on your video. Dr. Samir Trivedi has just joined us.
Hi, Gopi. Good evening.
Good evening. Thank you very much. Dr. Samir Trivedi is at BHU Varanasi. Dr. Ganesh Gopalakrishnan sir needs no introduction. The whole program is revolving around him. Dr. Arvind Panda, again, he is at KIMS Hospital. He is my colleague. He will, as Dr. Chandra Prakash will present the case, and Dr. Satish is there, Dr. Dheeraj is there, and so should we start, Dr.
Yeah, we should start. Please, we can start.
You can start. Yeah.
Am I audible, sir?
Yeah. You're audible.
Fine, go ahead. Good evening, teachers. I am Dr. Chandra Prakash, DNB Urology Resident, KIMS Hospital. Here is the case. A 28 years male patient, Mr. Rangaya Ali, case of RTA on 23rd/8/2020. His motorcycle hit a small tractor. Police catheterization was done in local hospital for acute retention of urine. Presented on 38/2020 to our hospital. He presented with lower abdominal and scrotal pain, scrotal swelling, and pain over left hip. Hematuria since catheterization.
Stop.
Can I ask the question to the PG? Who is the PG, please?
Dr. Satish and Dr. Varun.
Can we ask Dr. Varun to start the ball rolling?
Yes, sir.
Varun,
sir,
what do you think went wrong here? He had the accident on the 23rd.
Yes, sir.
And retention, and then 1 week later he comes to KIMS Hospital with this problem. What do you think has happened in the last 1 week?
Sir,
Sir, I want to know the clear history, sir. Actually,
this is the clear history. This is the clear history. It cannot be more clear than this. This is the clear history. That's all you've got.
I want to know whether he has passed urine since 1 week, sir.
No, he was on catheterization.
He was on catheter, no.
Okay.
But he has come 1 week later. There's a catheter in the urethra. He's come 1 week later with scrotal pain, abdominal pain, pain in the left hip, and hematuria since catheterization.
Yes, sir.
What do you think has happened here in the last 1 week? What do you think has happened?
So there might be a pelvic injury, sir. First of all.
Okay, there may be pelvic injury. That is known, isn't it?
This meeting is
all the
being
bother of the
recorded.
orthopedic fellow.
Yes, sir.
He is come to urologist now with this problem.
Yes, sir.
What is your worry? Are you happy with the situation or you are not happy?
No, sir, not happy, sir.
Why? What is wrong? If you see this patient in the casualty in KIMS, what is the first thing you will ask? What is the first thing you will do? Police catheterization was done in the hospital for acute retention. He's got all this problem. What's the first thing you will check? His blood pressure, everything is all right. Don't worry about all that.
Whether there is a hematuria.
Sorry?
Whether there is an hematuria.
Hematuria since catheterization.
Yes, sir.
What were the consequences at the time of this? And
I can see a lot of answers on the chat
Yes,
box.
sir.
If you open the chat box, you will get all the answers. Who's the other?
Good evening, sir.
Dheeraj, Dr. Dheeraj, what do you think has happened here?
So probably there must be.
Satish is there or Dheeraj?
Yes, sir. I'm there.
Who's answering now? Satish, eh?
Yes, sir.
Okay, tell me what do you think has gone wrong here?
Sir, after he had trauma, Foley's catheterization was done outside.
Correct.
But he's having hematuria.
Okay.
If it could be only an urethral injury. If it is not a bladder injury, it should not be hematuria. If he is having hematuria, maybe the Foley's is not in the bladder. I think the bladder should be. We have to examine per abdomen whether the bladder is palpable or not.
Okay, it's very difficult now. The lower abdominal pain, scrotal pain, you don't know whether bladder is palpable clinically. What do you suspect here?
There is extravasation of urine.
Extravasation of
urine.
Urine. Where is it extravasating?
He is having both lower abdominal pain as well as scrotal pain. So I am thinking that due to the urethral injury, the urine might be coming from into the.
But he's got a Foley's catheter, no? They say he's got a Foley's catheter.
Yes, sir.
What is wrong? Foley's catheter is there. Then how can he have swelling?
Maybe the catheter is into the collection, sir, not into the bladder.
How do you know it is not in the? How do you know it is not in the bladder clinically?
Because he is having hematuria.
I am saying that the catheter is in the bladder. Can he still have hematuria? I am saying the catheter is in the bladder. Can he still have hematuria?
Yes.
What is the reason? Catheter is in the bladder, but he still got hematuria. I concede your first point that catheter may not be in the bladder. But I am saying catheter is in the bladder, but he is still having hematuria. Any reason?
If associated any bladder injury.
Very good. Yes, associated bladder injury. Correct. So now tell me what has gone wrong here. We'll shift to Dheeraj. Dheeraj, you're the other guy. You answer. What has gone wrong here? What is happening here?
Sir, probably extraperitoneal bladder injury with the Foley catheter probably might have gone into the pelvic hematoma, so that he is having hematuria since catheterization, and that lower abdominal and scrotal swelling is probably because of urinary extravasation.
Okay. Can you tell me the anatomical boundaries of why this is like this? What is limiting it? It's only the lower abdomen, scrotum. Is there any limiting? What is the boundaries?
Sir, it is bonded inferiorly by collis fascia till that it will grow, sir.
What is the attachment to the collis fascia? Posterior and laterally, what is the attachment? What is the posterior attachment to the collis fascia and lateral attachment?
So laterally it will go till anterior thigh, sir, till anterior thigh, into the
anterior thigh. It's not going to thigh yet. Huh? If you are looking at the perineum every day, you must know where the attachment to the collis fascia is. Huh? Varun, can you take that answer? Can you take that question? Attachment of the collis fascia.
Posteriorly, it is attached to the perineal body, sir.
Very good. And
laterally, it is attached to a ischium.
Posterior only perineal body or something else? It's a sheet, isn't it? It's a sheet going up. So posteriorly attached to the perineal body, and it's very important. This question that I'm asking is very important because when you see subsequently X-rays, you will be able to figure out as to why this has happened in this patient.
Laterally, it is ischial
rami or pubic rami. Posteriorly, the collis fascia is attached to the perineal body and to the urogenital membrane, diaphragm. And laterally, it is attached to the pubic rami. Remember this because you will see something, and when we see some X-rays, obviously they're going to show some X-rays. We'll try to figure out as to why this happened. The anatomical basis for this. Okay. So now what are you going to do? They have admitted by orthopedics for further management, referred to urology for hematuria. I'll hand over to Dr. Samir now.
No, sir, you carry on.
नहीं, अरे यार, नमस्कार जी.
Good evening, sir.
Namaskar ji.
Namaskar, sir.
Take over, boy. Next slide.
Now let's move forward in the case. Yes. Who was presenting?
Chandra Prakash.
Yes, sir. On examination, patient was on examination, patient was conscious and oriented. His febrile pulse 99 per minute, BP 106/70. Chest is normal, bilateral air entry present. Parabdomen tenderness present and tenderness over the right side scrotal region and swelling present. Police catheter in situ, hematuria present. Tenderness and swelling present over the left hip. Distal pulsations were present. The range of movement of left hip was painful. Pelvic compression test positive.
Is the examination finished?
Next slide.
On examination, scrotal swelling. Catheter was no sir. Catheter was found to be displaced. On DRE, prostate was not clearly palpable. In view of blunt trauma abdomen with hematuria, CECT abdomen with the delayed films were requested.
Dr. Varun.
Yes, sir.
Anything noticeable about examination findings? You want to know something else? Are you clear with what has been told to you?
So they said that catheter was displaced. I want to know whether the catheter is in the bladder or not.
How do you know that on examination?
I examined that patient that time. So when I meant displaced, that when the catheter is in the bladder, there's only a small amount of the catheter protruding out of the urethra. In this particular patient, it was slightly more than normal. That's all. At this point, we don't know. We cannot say whether it's in the bladder or was it where it was. Only little more of the catheter appeared to be out of the urethra.
Okay, sir.
Any clue about the extent of hematoma which Ganesh sir was asking you earlier on examination?
So now there is a scrotal hematoma. Yes, scrotal hematoma, sir. According to the examination, scrotal swelling. So there might be injury to the scrotum or extravasation of the urine into the scrotum, sir, after injury.
Okay. You agree that you want to do a CECT?
As it is a blunt trauma abdomen, initially I want to know any other abdominal injuries or pelvic injuries. If he is stable, then I want to go for CECT, sir.
You like to do any investigations before CECT? Any blood investigations?
Yes, sir. I want to do renal function test, sir, before that.
Okay. All right. Chandra Prakash?
Yes. Can I ask you a question, Varun?
Yes, sir.
Okay, the X-ray is there of the pelvis. They have put the X-ray of the pelvis.
Yes, sir.
Can you give a comment on this?
This is X-ray pelvis showing both hips also, and there is a white pubic diastasis seen. I couldn't appreciate any fractures. The sacrum appears to be normal. Sacral alone, sacral iliac joint appears to be normal, sir. And there are no other radiopaque densities seen.
Do you know the classification of pelvic fracture?
Yes, sir. There is a tiles classification.
Is that the one that is used nowadays or another one?
Young and Burgess classification.
You know that?
Yes, sir.
In that classification, where does this fit in?
Anteroposterior compression fracture, sir.
What is the key in that?
Sorry,
what is
sir?
the most important thing in that category? AP compression. You see it in front of you.
Yes, sir.
But
pubic diastasis.
Yes, pubic diastasis.
Yes.
Huh?
Yes, sir.
Of the classification of Young and Burgess, for a urologist, which is the most dangerous? Which is the most tricky one? Shall we say?
Lateral compression fracture.
Lateral compression or the one which is a Malgain's fracture?
Malgain's.
Yes, sir. Malgain's. Yes, sir.
Why is that important for us as a urologist?
Because pubic rami fracture, inferior and superior pubic rami fracture causes displacement.
Anything else in the Malgain fracture?
Yes, sir. And sacroiliac joints. Sacroiliac.
So how is that connected to us, to urologists?
Sacral nerve roots S2, S3, S4 will
Very
go
good.
along the sacral nerves.
Very good. So, what will we do? What are you going to look out for?
Because of that, there will be bladder denervation also, and there might be retention of urine because of the injury. There may be neurovesical dysfunction.
Neurovesical dysfunction, but he's already got a urethral trauma.
Yes, sir.
So, how will that factor in? How will that injury factor into your treatment? Supposing he has got a urethral injury, he has.
Yes.
There's no doubt about it.
Yes, sir.
How will that finding factor into your treatment? If he's got a urethral injury, you will have to do urethroplasty, isn't it?
Yes, sir.
So how will that injury and that finding factor into your treatment? Will you counsel the patient? Will you warn him? What will
yes,
you
sir.
say?
I will counsel. Even of the surgery, even if the urethroplasty is done, patient will have urinary incontinence and erectile dysfunction because of the injuries.
Will he always have urinary incontinence or will he have something else? Which is more likely? Will it be urinary incontinence or?
What type of neurological dysfunction, sir, is asking you? The bladder dysfunction. What type it might be?
Yes. Will be unable to urinary retention, sir.
Will it be painful or painless?
It will be painless, sir.
So, what sort of incontinence is he likely to have?
Yeah, he will be having overflow incontinence.
Yes. Correct. You know the answers. You just not, you know the answer. You just think about it. You will figure it out. It's straightforward there. Huh?
And therefore, in examination, look for BCR and perineal sensation and those things.
Yes, sir.
You understand what Dr. Samir is telling you, isn't it? Yes.
Yes.
Okay. So proceed. Now what you will do? CT scan.
CT abdomen was done.
Axial films of CT pelvis.
Next film. Stop.
Yes.
What do you think is happening here?
This is an axial cut showing the perineal area, sir. I can see a probably that may be a scrotal hematoma, sir, collection in the scrotum. And I can see the catheter passing in the midline with the bulb in the perineum, sir. And there is also a contrast extravasation around the bulb of the police.
Okay. What else is there in the scrotum?
Heterogeneous area, sir.
Scrotum is enlarged, no?
Yes, sir. Scrotum. There might be a hematoma, sir.
What else?
Heterogeneous area.
What is that black thing? There's something black inside there.
Yes, sir.
What is it?
Necrosis.
It's a necrosis.
It's absolutely black.
Then it might be the air pocket, sir.
Air or?
Necrosis.
Huh?
Necrosis, sir.
Okay, there could be air inside, or there could be any other structure can go inside the scrotum. Just think laterally. Incidentally.
Fat can go, sir. Momentum.
Fat can. Yeah, momentum.
Momentum. That's momentum.
Yeah. Okay. So, now what you will do? Are you happy with the position of the catheter, or will it?
No, sir, not at all, sir. It appears that it is not in the bladder, sir.
So what do you think is happening here?
During catheter insertion, there is a false passage created and bulb is inflated in the urethral perineum.
In the perineum or in the retropubic space?
Yes, sir, retropubic space.
Ah. So what you will do now? You want to see some more X-rays?
Yes, sir.
You got any more CT images, Arvind?
So we didn't load in the presentation.
Okay, it's all right. This is okay. हाँ भाई समीर साहब पूछो.
Yes. So what next? I think Dr. Dheeraj should answer. Varun has answered a lot of questions.
Yes.
Dheeraj.
Sir, next I will look for the proper investigation, sir, regarding CBP. And also, I want to look about serum creatinine. As the CCT is already done, his serum creatinine must be normal.
Yeah, that we have covered. It was normal.
Yes. And depending upon the extent of collection, I'll plan for further management, sir.
How will the extent of collection affect your management?
Sir, if the collection is more and the serum creatinine is raising, but in this case it's normal, so I'll probably go for suprapubic cystos, catheter placement.
Otherwise, what is the other option?
Pardon, sir?
What is the other option?
Sir, open exploration and evacuation of contents.
Are you considering that?
Pardon?
When would you consider an open exploration and evacuation of hematoma?
Sir, if associated orthopedic bone injuries are being tackled, then on the time itself we can go for exploration. And also if there is bladder neck injury.
No, I think if there is associated bladder neck injury or
Yes,
if there is rectal injury, then
yes,
you can think of considering an open exploration. Otherwise, let the orthopedicians do their job. Why do you want to interfere with a pelvic hematoma, which is most probably infected? You can simply do an SPC and come out. What is the problem with that approach? The indications for open exploration of pelvic hematoma are quite specific.
Yes.
Hemodynamically unstable patient, he is being explored for concomitant rectal injuries.
Yes.
Bladder is not properly palpable. You don't have access to ultrasound guided SPC. You're not sure whether what you're feeling in the suprapubic area is a bladder. It might be a hematoma. The bladder is displaced. Then you can do an open kind of thing. Otherwise, I don't think so. Yes, sir. Ganesh, sir, what do you feel?
No, carry on. I presume you understood what Dr. Samir was talking about.
Yes, sir.
The catheter is not in the right place. Patient has suffered for a week. He has got pain, he's got tenderness. There is obviously some infection going on here. The urine is extravasating out. If you go back on the previous film, see the previous X-ray, the previous CT scan, they show you the bladder, isn't it? And that bladder seems to be reasonably intact. Although it's not completely filled, it's reasonably intact. See that? The contour is there, just that it's not completely filled, and you can see that there is not much of injury there. Satish, let me ask you, I am suspecting this bladder looks all right, but I'm suspecting that there is an extraperitoneal injury in the bladder. How will you find that out? At the moment, this looks all right.
Yes, sir.
But what is the key to finding out an extraperitoneal injury to the bladder on a cystogram?
Cervical collection and
how will you establish that 100%? There is a patient who has had extraperitoneal bladder injury. You do a cystogram and you show the X-ray to the boss and you tell your boss, you show it to Dr. Samir, and Dr. Samir says, I am not happy with this X-ray. I think this patient has got, have you ruled out extraperitoneal bladder injury? How will you rule that out? What is a classical radiological sign in extraperitoneal injury?
Flame.
Flame, yeah, correct. Flame-shaped extravasation.
Yes, yes.
How do you get that? How do you get that flame-shaped extravasation? Right now, there is no flame. You achieve the flame by taking a film after the bladder is empty. So when you have full bladder, you may miss an extraperitoneal injury. So you empty the bladder and then you will see the flame-shaped hemorrhage because that's where it leaks up. These are small tears and they can be missed because when the bladder is distended, it looks like that. When you deflate the bladder, empty it, then you will see. Since most of the time we put an SPC, we take care of many of these small little tears which might happen in the bladder. But you will recognize this at the time of surgery sometimes if you do an abdominal approach to these patients because the bladder will be stuck. The bladder will be stuck to the back of the symphysis pubis. and then you begin to suspect. Or when you do a suprapubic scopy, how will you make out if there was a bladder neck injury, Satish? If I do suprapubic scopy, how will I make out bladder neck injury?
Looking at the bladder neck, the shape of the bladder neck, any like
what?
On scopy, sir is asking you.
What about you, Dheeraj? Can you answer that?
Sir, distorted bladder neck, sir, and also there is playing of the trigone will be there. I mean,
Okay, there are certain types of bladder neck shapes which are described in patients who have had bladder neck injury. So you are expected to know that both radiologically as well as endoscopically. Okay, we all used to seeing a bladder neck which is nice and a shape which is got a spherical or even a nice elliptical shape. But sometimes in patients who've got bladder neck injury, you can imagine the bladder neck is being stuck to the posterior wall of the pubic bone, so it gets pulled to one side. And therefore, you can either get a rectangular shape or even a crescentic shaped bladder neck, because that's where it is being pulled or attached to the back of the pubic bone. And this can be seen on a radiological picture also when you do a cystogram or a micturating cystogram on this patient. Okay, you begin to suspect that. Okay, sir. Sameer, sir.
Dr. Satish, what do you call that cystogram which is done for suspected bladder injuries? There is a name for it. Oh, let's not waste time. It's called as a stress cystogram.
Yes.
And the point sir was making about emptying the bladder and then taking a film. That is absolutely crucial when you do a stress cystogram. Stress cystogram is you fill the bladder slowly up to 300, 350 ml and then ask the patient to void. But if you do a CT cystogram, then the post-void films are not required, because CT can tell you about the posterior wall tears as it is because of reconstructions. But in a cystogram, you have to take post-void films.
Yes.
Okay, so let's proceed.
We can proceed.
Carry on, Sameer, sir.
Yes, what do you want to do, Dr. Satish, next?
Sir, first I want to do a suprapubic cystostomy, sir, to divert the urine, because the catheter is not in a correct place and already the patient is having collection. So first I want to divert the urine diversion through HPCC.
Okay.
Then after stabilizing the patient and also from the orthopedic side, then I will go, I'll try to do an RGU, sir.
Any role of urine culture or anything?
Why do you want to do RGU so quickly?
See, the patient has had injury on 23rd, 30th he has come to the hospital. You are putting SPC. When will you do the RG? You'll do it the same day? What are you going to gain? You've already done a CT scan and everything. What is the RG you going to do now? Dr. Sameer wanted to know the immediate management, and you should have stopped with SPC. By doing RGU and all, what are you going to get? You're going to cause more problems with infection. Dr. Sameer is talking about infection, no? It will cause more problems with infection.
And the patient also needs orthopedic treatment. So you divert the urine, let the patient be stabilized, let the orthopedic part be complete. Now there is no urgency. The extravasation is not very gross. If you divert the urine proper with the proper SPC and give him proper antibiotics and supportive treatment, your role temporarily would be over.
Yes.
And once the patient is stabilized, then you will come back into the picture. At that time, you would consider doing imaging studies and all, not immediately.
Yes.
When will you do immediate RGU? Dheeraj, when will you do immediate RGU?
Sir, if you are suspecting that, just to see whether the urethra is intact or not, sir, so that we can place a catheter, gentle attempt of catheter can be tried, sir.
So what is that classification?
Sir, Goldman's classification.
You know it?
Yes, sir.
So we won't waste time if you know it. We assume that you know it.
Yes.
In the real exam, you will be able to tell the fellow, because he won't say we'll assume it. Okay. Lack of time.
Okay, I think we can move ahead. The next slide.
Move ahead.
Okay. All right. Next.
Dr. Varun, anything particular about this SPC? You are doing the SPC. You want to?
Yes, sir.
What sort of SPC you will do?
Want to do a SPC about 5 centimeters above above the pubes, sir, in the midline.
Why 5 centimeters?
So if you are planning to do a intervention later, antegrade scopy will be easy, sir. When we do scopy.
Anything will be more easier than antegrade scopy. Antegrade scopy you can do very well. What is it?
Passing a Hague shaft also will be easy.
Right. So that's called a high SPC. Will you do this SPC under a trocar type or will you do open? This patient. Will you do trocar SPC or will you do open?
Trocar is fine, sir.
Trocar is fine.
Do you always do trocar SPCs in all your patients?
No, sir.
Where do you consider other forms of SPC?
During buccal mucosal graft urethroplasty also we do a open SPC, sir.
Buccal mucosal graft urethroplasty.
Why do you want SPC in a buccal mucosa?
To divert the urine sometimes.
You want,
no, we are talking about this case.
No, sir.
Dr. Samir is talking about this case.
Sir.
Why are you talking about buccal mucosa? We are asking, and with reference to this case, will you do open SPC or will you do trocar SPC? With that, Dr. Samir tried to give in which situation will you do trocar, when will you do open? That's all you want.
Sir, in this pelvic hematoma is there, sir. So I like to do a open SPC in this case.
See, don't feel shy about saying something that is safe.
Yes.
Very important. Just because some other fellow is doing a trocar and he's very good at it doesn't mean that you may be happier doing SPC. The idea is that you want to do something safe. There is hematoma there, 7 days has happened. Can I feel the bladder? I don't know what's happening there. Nothing is lost by making a small incision and being 100% certain that you are in the bladder. Isn't it? That is your main aim. So nothing is lost. There is no machoism, there is no ego lost in this. Put it. Tomorrow your boss is not going to come and fire you because you did open SPC. If you tell him, I did open SPC, boss, sir, because I was not happy. I couldn't feel the bladder. There was a lot of hematoma there. So I just made incision, put the picture. Very good. Halas, you want to be safe. Already drama has happened with this patient. You don't want to add insult to injury here. Okay?
Okay, next slide, Chandra Prakash. Let's move.
Then followed by orthopedic intervention with scrotal hematoma drainage and sec.
Okay.
Do you agree with the orthopedic intervention?
Has it done any good to the patient?
Stabilization of the pelvis.
What are the methods you can stabilize the pelvis?
Have you heard of fixators? Have you heard of external fixators?
Yes.
Okay.
Continue, Chandra Prakash. Next slide.
After 4 weeks following orthopedic intervention, a patient presented with pain in the lower abdomen at surgical site, no history of fever. On examination, tenderness present over suprapubic region, 2 into 1 centimeter wound gaping present, first discharge present. Then patient underwent wound debridement, secondary suturing was done.
Dr. Varun, what is your worry in this case?
There is a wound debridement, there is a infection, sir, main worries.
What else is the problem here? You are worried. I'm very worried when patient like this happens, 2 centimeter wound gaping, first discharge. Why is it worrying?
Infection, there will be a lot of fibrosis, sir.
Apart from that, fibrosis because of injury itself. Yes. But as a person who is going to do a reconstructive operation in the future, yes. Is this thing worrying you?
Yes, sir.
What? Why?
There might be other tracks also, sir, because of wound infection, fistulous tracks.
No, there's no other tracks. There's first discharge, SPC in situ, 1 month after the whole procedure. Dheeraj, are you particularly worried about this?
Sir, probably because of orthopedic, this internal fixation was done, sir. Hematoma may cause a secondary infection and it may cause leading to abscess formation and all. And it may cause further scarring.
What is the main worry here? Huh? Is there a foreign body sitting there?
Yes, sir.
Huh?
Yes, sir.
And will this pus ever go if there's a foreign body sitting there?
No, sir.
What type of pus are you worried about? What type of organism are you worried about here?
Staph, sir. Staph aureus.
Yes. Any other bacteria worried about in this situation apart from staph? What particular staph?
Staph epidermidis.
No, which variety? I am asking this question because you will be putting knife to the perineum or maybe in the abdomen after some time. And then you should know what you're going to deal with. Which type of staph are you worried about?
Staph epidermidis. And also
that is same epidermidis staph. Have you heard of MRSA?
Yes, sir.
Is that a dangerous type of infection?
Yes, sir.
Very dangerous. Huh? It might necessitate asking the orthopedic fellows to take up all these screws, man. The screw, the plate and everything. Huh? So, as a urologist, it's very easy. You will just say, okay, I will do this operation. But the whole thing can fall apart. The whole procedure, because you're doing a reconstructive operation. The other organism, any idea what is the other worrying organism in this situation? Dr. Varun or Satish, any idea? What's the other organism you're worried about?
Pseudomonas.
Pseudomonas anyway is in hospital.
Klebsiella.
There's another, well, Klebsiella is a standard now. Everybody's got Klebsiella in the news. We don't see it much, but you may begin to see it very soon in some bigger hospitals. It's called VRE. Vancomycin resistant enterococcus, streptococcus. It's a dirty bug. Okay. So these are things that can actually transmit bacteria. You can go from one patient to the other. It's very serious matter. So we must be sure that these patients are not having this sort of bacteria when this pus is being cultured. Okay. Right. Carry on. Sorry, this was a sidetrack from that, but you know.
Then he was kept on 3-weekly SPC change and planned for a definitive management after 6 months after injury. Urine culture sensitivity after 6 months showed carbapenem resistant Klebsiella.
Okay, carry on.
Next slide.
Then
Yes, Dr. Satish.
Sir.
This culture showed active infection of an organism which was resistant to carbapenem, and now they have done an RGU and MCU. So, you agree with the course of management?
Before we do an RGO, we have to treat that urinary tract infection, sir.
Is your aim to make the urine sterile?
Yes, sir.
Is it possible to make the urine sterile? A patient is on indwelling SPC for a long time, although it is being changed. But do you think a sterile urine can always be possible in such a scenario? So don't wait for urine to become sterile in a patient on SPC. Clinically, there should not be any infection.
Okay, sir.
Okay. So he must have been given antibiotics and all, and then if at all there is a possibility of infection, you should do RGU-MCU under the cover of antibiotics.
Antibiotic.
How will you make sure the culture is a proper collected sample?
Taking the urine sample through after inserting a new SPC tube, sir, not from the old one.
Very good. So you take this out, take this catheter out, put a sterile catheter, do it like an operation, then only take that sample. Don't take it from the bag and from the tube and all the rest of it if you want to be sure about the bacteria. Okay?
Yes.
Right.
Okay, so they have done an RGU. Is it enough for you?
No, sir.
What do you want?
I want a micturating cystourethrogram, MCU also.
So you want an RGU or an MCU or both?
Both of them, sir.
Separately or together?
Together.
Okay, so you want a combined study.
Yes, sir.
Okay, so these are the two films. RGU you have seen, and this is an MCU.
Yes.
No.
MCU was done. Then at the time of MCU, he had severe chills and raggers during the procedure, so that MCU had to be terminated.
Can you describe the findings of RGU and MCU?
Back.
Anyone? Dr. Varun?
Yes, sir. It's a right oblique position, sir. There is a contrast. After injecting contrast, you can see the penile urethra opacifying normally, and it is opacifying until bulbomembranous junction, sir. And I can see the previous orthopedic intervention screws and plates in RG.
What is the aim of giving the oblique position?
To know the to see the entire length of the urethra, sir. And also there will be overlapping of the urethra, and there will be curves detected in the RG, sir, if we do it anteroposterior.
Okay. What size catheter? Do you do MCU, RGU MCUs yourself, or you send the patient to the radiologist?
Myself.
You do it yourself?
Yes, sir.
All right, let's not waste time. We can go to the MCU film. Let me describe the MCU film.
Micturating cystourethrogram showing bladder is smooth in outline and adequate capacity. There is a vesicoureteral reflex on the both sides up to the pelvis. I couldn't see the bladder next to whether this is micturating or it is full bladder.
This was the initial film when they tried to fill the bladder. We did not do any other micturating film after this. First film, so a plain film, and then this was an attempt to get a full bladder. The second film, so as to say. First was, of course, a plain X-ray QB. The second was attempt to get a full bladder. He had chills. We stopped it.
Is there some explanation for these chills here?
Because of urine culture is positive, and there is also reflex into the both kidneys.
Why is there reflux? Is this congenital reflux or is it acquired reflux?
No, so this is acquired reflux, sir.
Why is there reflux?
There might be due to bladder outlet obstructions, or because the fold is inserted in the false tract, there is obstruction in the urethra.
When this is not, there is no Foley's in the false tract.
6 months down the line.
6 months afterwards, when this is.
So because of the infection, also there might be a reflex on both sides.
Is there any telltale sign on this X-ray? Is there a telltale sign on this X-ray to indicate yes, there is a reason for reflux, and that is the reason? You made a statement, no? I cannot see the bladder neck.
Yes, sir.
But you can see something else.
Sir, until
you can see something else, no?
Yes, sir.
What is under below, beyond the screws, the plate and the screw? Can you see some?
Prostatic urethra.
Yes.
Sir,
you see some contrast there, no?
Yes, sir.
Isn't there some contrast there? Huh?
Yes, sir. Yes, sir.
You have seen the RGU, no?
Yes, sir.
Was the RGU, the contrast entering the bladder? Dr. Samir wanted you to explain that RGU, but you didn't. Is there any contrast going in the bladder?
No, sir.
So, can you match these two and explain to me as to why he's got reflux?
Because of back pressure, straining.
He's in effect doing A dysynergic voiding.
Yes.
All right. There's an obstruction. You put contrast inside and say pass urine. You're now putting against the resistance. There's a block there. Isn't it? So it will reflux up. And bacteria is going up and therefore fever. So here you have a reason. In some patients, they may not void or the bladder neck may not open. And still they have reflux. That is because of the edema around the orifice, etc. But this is a situation where you see the bladder neck is open, the contrast, and it's possible that with the infection has produced a detrusor overactivity, an unstable contraction as we used to call it in those days. And that is because of a dysynergic voiding and is refluxing there. There's an obstruction. He's voiding against a closed outlet. Okay. That's why the fever witches.
And when you mention reflux, also mention the grade. Always. Okay, carry on. Yes, Chandra Prakash, please move it.
Then he was immediately started on Zavicefta, which was continued for 12 days.
Okay, carry on.
Then on antibiotic cover, definitive management was done. End-to-end anastomotic urethroplasty on 16/4/21.
Very good.
So, Dr. Satish,
sir,
do you think it would be a straightforward routine end-to-end anastomotic urethroplasty, or do you anticipate some difficulty? Any further workup which you want to do before doing a urethroplasty?
Looking at the RGA film and MCA film, because both of them are not combined, but I am thinking that the both urethral ends are near to each other, which we can do with an end-to-end urethroplasty, sir. If needed, any ancillary procedure, we can also do an elaborate perineal urethroplasty, sir, to bridge the gap.
Any role of finding out about erectile function of the patient?
Before proceeding for the surgery, we can do a penile Doppler, sir.
In all cases?
If in local examination we had any if the glands was cold or like it was having numbness, and then we can plan for a penile Doppler, sir.
On examination, if the glands, is that what you're saying?
Yes, sir.
Why can't you ask the patient about infections?
Where is this data?
And if it would have been like that, indications for I'm thinking of indications for penile Doppler, sir.
No, but first you ask the patient whether he has got erectile dysfunction or not.
History is important.
Yes.
Yes.
What is the incidence of erectile dysfunction in PFUI?
40%.
30 to 40%.
Only?
Slightly higher. Some studies have gone up to 60-65%, but people usually accept it around 45-50%.
40. Yes.
And is it due to what?
Vascular.
Erectile dysfunction is due to what?
It is due to the injury, neurogenic more than vasculogenic. Sacral plexus, sir.
Sacral plexus.
Vascular.
Then we'll have to go on to asking you about the nerve supply of penis and pathophysiology of erectile dysfunction. Let's not go into that direction. Probably you need to study it a bit.
Correct.
Because we are already running late. What do you call this type of urethroplasty which is being done for PFUI?
Progressive perineal urethroplasty.
Just tell the steps fast.
Complete bulbar urethral mobilization.
Till what?
Separation.
How do you know it is complete, the mobilization? What is the landmark?
Distally up to the penoscrotal junction, and proximally we have to lift it from the perineal body, sir.
Perineal body only. We have a steps of this thing.
So
the idea is to go right up to the point where the block is. So you keep dissecting till you reach the end point. And this may be at the level of the urogenital diaphragm. Okay, the bulb here is intact. The bulbar urethra is intact.
Yes.
So you see things beyond the bulbar urethra right up to the membrane.
Okay, sir.
And you know, if you look at the RGU, that is at the level of the perineal membrane because that is where it is attached. And if you draw a line through the obturator foramen, you will see that. Although it's a little displaced, you can make out. That's where the perineal membrane is. And in many cases, fresh cases, you'll be able to see the perineal membrane actually. Nicely as a white sheet between these two layers of between the two pubic rami. Okay, so that's what Dr. Arvind wanted. Not only up to the bulb, but beyond the bulb. Because if you go up to the bulb, you may sacrifice some bulb beyond, some urethra beyond that by mistake, and that's very vital. You need to get as much of urethra as you can, because you still have to trim back some urethra to get normal urethra both ends. So that's why you go as far as possible. If you cut it at the bulb and you find that you're short, then you're in trouble. Every centimeter makes a difference here. Okay?
Gopi, how much time do we have? We have already
Next slide. Next slide.
Yeah, I think we have.
We'll just quickly go. Okay.
Quickly, Arvind, you tell us what happened.
The next slide. Next slide. We'll just go through this.
3 weeks later, post endo to it.
Next. Okay, no. Go to the next. This is fine. We'll just go to the learning points.
Yes, learning points.
No, back. So, no, back. First slide. Before this. Yeah. Of course, this patient still had an issue. You can say that ED, erectile dysfunction, was still present after the surgery, though he is now voiding well. Now, this is, sir, the difference you could tell, sir, about strictures versus distraction.
Go ahead, Arvind.
So the learning points are basically, this is a posterior distraction defect. It should never be called as a posterior stricture because posterior stricture is never primary. It's always a result of a failed surgical repair. And this is a distraction where the distraction of the prostate happens from the membranous urethra associated with pelvic fracture. So this is the difference. Next slide.
Can I just add a point, Arvind? I just want to add a point there.
Yes.
You have two entities now. One is called urethral stricture. The other is called urethral stricture disease.
Yes, sir. Right? Of course, yes.
It's a different variety, and like conditions like BXO and all that will come into urethral stricture disease. Okay, carry on. Just want to make that difference now because people are looking at it very seriously. Yeah.
So this, when you're talking about surgery for posterior distraction defect, there's a stepwise approach. First is, as he said, mobilization of the bulbar urethra till the pinoscrotal junction, identification of obliterated segment with urethral division, crural or the corporal body separation, infrapubectomy if required, and identification of the proximal line with excision of wall callus. There are two more steps, which is actually prostatic mobilization and corporal plication if needed. This was described by Dr. Ganesh earlier, both these steps. Webster had described the first 4 steps in 1986. Next slide. So the additional steps, sir, can explain. I think, sir, you are the best person to explain this. Why we need to do a prostatic mobilization and a crural plication. So you can actually add 3 to 4 centimeters more if you do these steps.
Carry on, Arvind.
Okay. So basically, when we talk about crural plication, this is the crura, and if you plicate them, we'll get a little bit of extra length there. Next slide. So again, this is a discussion. Actually, I'm sure the faculty can add to it. Now, this is about doing the posterior dissection. Not everyone does it. Dissecting the prostate of the rectum. The advantages are it increases the length available by 1 to 2 centimeters. It allows for a smooth curved anastomosis, and it is a better and a more wider anastomosis. The disadvantage is that the neurovascular bundle is in this plane. But again, if you come back to the advantages, it definitely increases the chance of a perineal anastomosis, but it's difficult in children who do not have a well-developed prostate. I would invite comments from the faculty. So this, how does it differ from a bulbar anastomosis? Here, main thing is in a bulbar anastomosis, crural separation is unnecessary. It does not facilitate anastomosis. However, crural plication will work in both situations if the length is issued, And in a bulbar anastomosis, we can saturate both ends, which is not possible in this case. I would invite the faculty to make the points.
Samir, sir.
Sir, aap.
No.
You are the best person.
I think Arvind has very clearly mentioned what the steps are. And the only thing about this corporal plication, recently there has been a publication from Alan Morey's unit. They have called it extended penile anastomosis, EPA, I think it's called, extended penile lengthening. And they described the same thing actually recently, and where it is like a reverse Nesbit, you can call it. You know, Nesbit, we do it for patients who've got CODY, you just plicate anteriorly. The worry is in that these patients, the question is whether you are actually shortening the penis. You are not actually using these corporal plicating sutures on the pendulous urethra. You are using it on the fixed part of the corpora, which is on the ischial rami. So once you have separated out the pubic bone, you've done the pleural separation and done the pubectomy, it's after the inferior pubectomy that you resort to this before you actually go to either a total abdominoperineal approach, because that is even more morbid. And this gives you a little extra length, as he said. And in time, it doesn't actually shorten the length of the penis that's available because it is done on the fixed part of the corpora, not on the pendulous part. If you did it on the pendulous part, you definitely will have shortening. So that's why we call it reverse corporal plication, so that it's not confused with the standard Nesbit plication, which is done for hypospadias on the dorsal aspect. It does give some length, certainly in some difficult redos and all that. There is a question here which Arvind has pointed out, stripping of the facial layer of the spongiosum. Now, this is very important. And the reason is that this comes into play when you're doing redos. There'll be adhesions, it'll be stuck, and it may be difficult. So it's better to err on the side more of the cavernosal tissue because that can be closed. But if you begin to strip the spongiosum, then you'll have a very bare urethra. And you recognize this at the time that the urethra is actually very bare. When you actually put the catheter and see, you will actually see the urethra. You will see the catheter. So this is a dangerous situation because it's bound to actually cause ischemic damage finally. And this what actually leads to bulbar necrosis ultimately, and a very thin this thing. It's all vascular. And worse when you have multiple operations or by mistake. Now the thing is that in children this makes a big difference because it's not well developed. So what you normally do is you tend to take the bulbospongiosus muscle off and the urethra separately, and sometimes the children, because of